You're listening to Medscape's In Discussion series on multiple sclerosis, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Ann Cross. Dr. Cross is a professor of neurology and holds the Manny and Rosalind Rosenthal Dr. John Trotter MS Chair in Neuroimmunology at Washington University and Barnes-Jewish Hospital in St. Louis, Missouri. Relevant disclosures can be found with the episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for you as healthcare professionals.
Hello, I'm Dr. Ann Cross from Washington University, and I'm here to welcome you to Medscape's In Discussion series on multiple sclerosis. And today we have my good friend, Dr. Scott Newsome, as our guest to talk about controversial topics in MS treatments. And in particular, should platform therapies, the injectable therapies like beta interferons and glutaminyl acetate, be used in newly diagnosed MS patients anymore? Let me introduce my guest, Dr. Scott Newsome. He is a professor of clinical neurology at Johns Hopkins Medicine, serves as director of the Neurology Outpatient Services and Infusion Center, as well as co-director of the Multiple Sclerosis Experimental Therapeutics Program. Welcome all to In Discussion. Welcome, Scott.
Thank you for the invite.
Before we get into the topic at hand, I'm wondering if you can tell us a little bit about how you got into the MS field.
Well, my mother had multiple sclerosis and she was a single mom. So I saw sort of the day-to-day struggles that she had faced. And that got me sort of interested in just helping people with chronic illnesses in general. And real brief, interestingly, I didn't think I would want to be involved in neurology in general, just given those sort of close to home experiences. But as I was going through, schooling, eventually was interested in going to medical school, and then in medical school led to neurology residency. And here we are now many years later. And I'll tell you, for me, it was the best decision that I could have made because it's very rewarding helping people who are living with MS every day. I think having that experience as a child has really helped develop, I think, a humanistic aspect for me for my clinical practice. Nowadays, it's so much different, as you know, and treating MS than it was even 10 years ago because of all the therapeutics we have and all the things we've learned.
Yeah, thank you, Scott. I will say that knowing you, and I'm sure your patients would say the same thing, the humanistic values you bring to the MS field, and I'm sure to taking care of your patients, really, really shine through. I imagine that experience with your mother obviously had a huge impact, and we appreciate you for being in this field. So you are the leader in the multi-center trial called Traditional versus Early Aggressive Therapy for MS, otherwise known as TREAT MS. And that is a randomized trial to compare initiation of lower efficacy treatments, like we just mentioned, the older injectables, but safer medications, the traditional disease modifying therapies, or using higher efficacy medications as the initiation for treatment. I guess I'll ask you about this study, what led you to do it, what's your main goal, and when might we hear some results?
We're incredibly excited for the Treat MS trial because I think we're going to learn a lot about our patients living with relapsing onset MS. It's not going to answer all questions, but it'll answer a lot. And we're very grateful to PCORI, a patient-centered outcome research institute, for funding this study, because I would imagine there's probably not a lot of organizations that would fund such a study. And again, we're just very appreciative of their funding and support. As you mentioned, I'm one of the co-PIs on this, principal investigator with Dr. Ellen Mowry, who is also at Johns Hopkins. And over the last several years to beyond, as I was alluding to, we've been very fortunate to have this expanding armamentarium of therapeutics for our patients. A lot of what we're leveraging our decision-making on for these therapies are from observational studies, retrospective studies. And we know that our current therapies that have arguably higher risk associated with them, including infections, there's a cumulative effect of that over time, the longer the person is on the medication. And so we were very interested in trying to develop a study that would look at treatment strategies where you take a big hammer to the immune system up front versus take, a modestly effective treatment approach and follow people over time to see, does either approach really impact future disability? One would argue that sure, in a short term clinical trial, maybe short term real world practice, cutting back on relapses, new spots on MRI, the early aggressive treatment approach, you could say, yes, absolutely. You put someone on infusion therapy versus an old injectable, we can all probably come together and say, okay, there's going to be a decrease in macroscopic inflammation in favor of the aggressive treatment approach. But what we don't know is, will that translate into preventing future progression? And I think that this was what we were most interested in looking at because of the risk that we're seeing associated with the stronger therapies over time. So the Treat MS trial is looking at this. And the way we developed it was we stratified people up front into whether we thought they were high risk versus low risk for future disability based on their presentation clinically and based on imaging metrics. And then once those folks were stratified in those respected buckets, there's a one-to-one randomization to that early aggressive treatment approach or that more first line modestly effective treatment approach. And we can talk more about some of the additional nuances, but the primary outcome for it is EDSS plus. So looking at sustained accumulation of disability in that expanded disability scale, or two subcomponents of the multiple sclerosis functional composite score, which is the timed walk and the PEG test that we do.
How long do you plan to follow these patients, and how many are in the study?
The pandemic has disrupted many things in life and in research, and so I'm going to try to take a positive spin from the pandemic. We started this study in 2018, and the original goal was to be finished actually shortly after the pandemic started, but then we had to shut down for a little bit of time. And so we fully enrolled as of this January. So 900 patients enrolled. It's a multi-center trial across the US, about 40 sites. And those sites are not just academic sites. We try to be very thoughtful about how can we make the results generalizable. And so we have academic sites, we have private practice sites, we have private sites, if you want to use that term. So it could be more generalizable. The primary results will be out next year. The close of the study, last follow-up, will be August 2026. It's amazing because, we're going to have a little over 8 years worth of data for some patients. And if we're going to really think about long-term disability, how can we really optimize preventing disability? We need time. A 3-year study, 4-year study is not going to give us that, I think, amount of information that we're most interested in. The other piece I'll just mention in our study, so that primary objective is, does it make a difference what you do up front treatment strategy wise? We also have a secondary sort of objective, and I think this is important because this speaks to that escalation treatment approach that is still very popular. So for those people that were deemed to be low risk for disability at the start, who are randomized to that first line modestly effective treatment strategy, if they have breakthrough disease activity, they're re-randomized 1-to-1 to, again, either a early aggressive treatment approach or that modestly effective first line treatment approach. And I think that that's going to tell us whether what we do up front, if maybe we, I don't know, didn't get it right the first time around, right? But you quickly escalate with first sign of breakthrough activity, maybe that's what we need to do, right? Maybe we'll find out it doesn't make a difference what we do treatment strategy wise, as long as you're monitoring people closely and you have a low threshold to switch therapies.
So are you using any other endpoints, some of the newer sort of biomarker endpoints and imaging endpoints in the study?
Yeah, so we have a whole slew of secondary and tertiary endpoints. How much time do we have? We'll be here for all day if we go through all of them. Some of the secondary and tertiary endpoints, not in any particular order. You mentioned imaging, so we are looking at imaging. We're lucky to have a great imaging analysis center, and so we're going to look at conventional T2 GAD-enhancing lesions, just like all other studies do. But we're going to be looking at volumetrics, not just whole body, like whole brain, but we're going to look at substructures, gray matter atrophy, so we're really excited about that. T2 lesion volume. We are looking at fluid biomarkers. So we're collecting blood, not on all people, but a good portion of people. The usual stuff, right? The NFL, GFAP, and then future biomarkers that are found and developed for MS. And we're going to have a repository for this for future analyses, which we're really excited about. Some of the other things that I think I'm really excited about is we're going to be looking at social status of patients, through their journey with MS. Are they still working? Are they still with a partner? Like things that are really, really important for our patients. Relapse recovery. Is there a difference between the treatment strategies if someone has a relapse? Also looking at things like symptomatic use or burden of healthcare, right? Maybe we'll find out that it doesn't matter what we do up front, like if we look at the conventional measures, but maybe within one of the treatment strategies group, someone is utilizing more symptomatic medications or going to physical therapy more often. And so I think that's going to be important to also look at. And of course, PROs. We love PROs. We're looking at PDDS. We're looking at other PROs to see how the patient's experience is with these treatment strategies.
Okay, yeah, those patient-reported outcomes are really important, we realize now, and I'm sure you're probably examining risks that occur or health risks that may occur, cancer rates and infection rates and that sort of thing.
We take a very detailed intake up front about medical history, and then each visit and even in between visits we're collecting that information. The other thing, just because I'm excited about this too, is we have, I would say, laundry list of questions up front for the PIs, the treating clinician, to fill out based on, okay, what is their clinical presentation? Do they have things like obesity? Are they smokers? And then what is their imaging markers up front as well? We're going to be able to, I hope, this is like pie in the sky, almost be able to develop like an MS risk score with all of this information, just like the Framingham score for cardiovascular disease. Maybe we'll be able to utilize the information from this trial to say, hey, plug it in. This is your risk score. And these are people maybe that, if we find a difference between the treatment strategies, that really should be treated early aggressive approach. So we'll see. There are so many things that we're going to be looking at in, I think, not just for now, but in the future.
I mean, this is going to be a wonderful resource. I mean, this is going to keep you busy the rest of your life, probably. So these 900 people, is there any hope for them being followed longer than getting out of the study a year from now?
Yeah, so as one would guess, we're trying to get funding for long-term extension, and we want to follow people as long as they'll want to follow with us. And I think the one, at least at this point in time, thing with our patients, it's a chronic condition, right? And they need to be seen every so often, anyways. And so we're going to really try our best to get funding to go as long as we can. Can't give you a specific time point, but we're just gonna keep going, and then we'll likely not capture all the things we're capturing, for the core trial, but certainly some of the very important salient outcome measures we're going to continue to collect.
I'm going to segue a little bit into another topic that you've written on and talked about a lot in the past, which is shared decision making with patients. And what is your own definition of shared decision making, and how do you approach that with an individual patient?
The definition and the concept of shared decision making has, I think, changed over time, not just for me, but for the community. If I'm seeing someone, whether it's a new patient or a follow-up patient that I've been seeing for, a decade or more, I always have at the forefront the patient. patient-centric care, and with that is the shared decision making. A shared decision is really when you're starting or switching a therapy, or you're deciding even something like, well, do we think you need physical therapy? I have an open and transparent conversation with the patient and see what their short-term, long-term goals are, try to get a sense of how interested or willing they are to do certain things. And then I share my opinion. And then we try to come together to figure out, okay, how can we set this person up for success in their journey with MS? And I try to teach our trainees this because I learned very early on my particular preference and ideas. You can't force on people. They're going to do what they feel is best for themselves, which is fine. And so I think the best treatment, we'll just focus around disease modifying therapies for a second. The best therapy for the person is the one they'll take, right? And so I may have an idea of like, gosh, I want someone to be on X medication or X class of medications. If they don't feel comfortable with that, they're not taking it. And in fact, I had this happen the other day where I thought we had shared decision making, and so comes on me. And the person came back a few months later and never started their therapy, and just didn't feel comfortable. And I thought we had come to an understanding, and I was like, "All right, we got it. We're going to get this person on medication." And apparently that wasn't the case. And so I think it's good to reflect on how you're speaking with patients. And do you really feel like you're having that shared decision making? And again, it's sort of a craft I think you develop over time. But at the end of the day, you have to listen to your patients because they're the ones living with the disease you're treating. And they're going to tell you whether they feel comfortable with that shared decision that you're trying to come to grounds on.
I have had very many similar situations occur where patients come in and they're not taking their medication and they haven't informed us. I would say it's probably taken me a couple of decades to understand and live with the idea that patients won't always do what I suggest they do. And once I think we understand that, we're all better off.
For those patients that you're not sure whether they're going to go out the doors and take their medication or go to physical therapy or improve their healthy lifestyle, do you have a practice in place where you reach out to them, or you have like your nurse or someone else reach out to them that have additional touch points or bring it back sooner?
Yeah, I would definitely bring that patient back sooner if I had any question about that. 2 months, 1 month sometimes, 3 months very commonly, to make sure that they're not sort of out there with no treatment. Nowadays, with Epic and other electronic medical records, we can contact them, and so there are some patients that you just worry about, as you know, that won't follow through, and so it's good to contact them.
I feel like utilizing technology and the short follow-up after maybe you make a diagnosis, I think goes a long way for patients and trying to get I hate to say it, but buy-in that, hey, we can treat this condition. We have so many things available now that can help you and can help prevent new problems moving forward. And I think it's all about education. And I think on the front end, that really can be helpful.
Yes. Do you have any at your place educational programs for new patients or things that you do to help people understand the disease?
We've tried a lot of different things, including like little pamphlets, and we have a website that has some information, of course, on it. I think we've found to be the most helpful is getting the person in front of you. Not that taking material home isn't important, but I feel like a lot of people, once they leave the clinic, especially early on, they want to forget that they have MS. They want to get away from what they just experienced, and maybe they don't like doctors. I think getting the person in front, or even a phone call from time to time, I think can be quite helpful. We've tried a lot of different things. I think it's still in evolution in my view. I don't know for your clinic if you found anything helpful.
Of course, you can't always predict who the person will be, but if you get the sense that they're going to be that person that wants to walk away and not do anything, this is where telemedicine has really been almost a godsend for those patients because you can have a visit with them, a virtual visit, without needing an examination room or anything. I found that to be helpful too, just to have a follow up if there's any question. And it can be by telemed and just sort of face to face.
That's a great suggestion. Absolutely.
If I had MS, I would want to be your patient. I will tell you. I think
Oh,
you're such a wonderful human being and doctor.
well, likewise. Likewise.
I'm going to move on and we'll talk just a little bit more about COVID-19 because we were both on a task force to talk about vaccinations during that period of time. And so I know you've thought a lot about vaccinations in general. I guess I would ask you, what do you recommend to your patients regarding vaccinations? And are there certain situations where you're recommending vaccinations more aggressively?
Yeah, so my approach with vaccines, let's just say broadly, are a couple things. So one, we usually will tell people not to get live attenuated vaccines or live vaccines in general, especially those that are on therapies that suppress the immune system because of the potential for patients to get into trouble from actually getting the illness that they're getting vaccinated for with the live vaccines. But the non live, I've been a proponent of having our patients go ahead and get those. And some of it depends on age, some of it depends on, yes, what therapy they're on. But it's routine for me to recommend getting the flu shot, getting the COVID-19 shot as well, and the boosters. If someone's of age, maybe the pneumonia shot, the Shingrix, right, for shingles, we will ask our patients to get that. And sometimes, even if they're not over the specific age for, let's say, Shingrix, but they're on a therapy that suppresses their immune system, I will ask for them to get it. So for different classes of medications, through the work group that we're in and some really nice studies that were done by many of our colleagues, we know for sure there are some classes of medications that put people at risk for developing infections, including COVID-19. And we know that with COVID-19, if someone were to get it, that on certain medications, they may have more severe outcomes, including death. So I'm very aggressive in telling people, okay, if you're on the class of medications that put people at risk for more severe outcomes of the illness that they may get, or they're more susceptible to getting it, let's get you vaccinated. And then there are, depending on the treatment, guidances around when should you do it to maximize your vaccine response. I think we're still learning about that because the humoral or B cell response is not only the important piece to vaccines, right? T cells are also involved. And so you wonder whether the humoral response or the B cell response is blunted, but does the T cell response step up into action to help compensate for it? So maybe we'll learn, just get vaccinated whenever. There may not be a timing. Shared decision making. I can tell you, I have plenty of patients to this day that do not want to get vaccinated. And I'm not going to force it. We just have to do the best we can and counsel those patients with behavioral interventions. Make sure, you wash your hands. If you're on a plane and you're on certain medications, mask up still. Not everyone's going to do it, but in my clinic, we still are in favor for vaccines.
Thank you. That's pretty much what we do as well. Lately, I've been particularly worried about a group of people who were born in the 1950s, let's say, 40s, who did not get measles vaccines and may or may not remember if they had measles. Have you been doing anything special with those people?
This is hard because, at least within our area, we have not had an outbreak. And fortunately, but of course, we take care of people in areas that there is. And my general recommendations has been look at your general area, and if there is an increase potential for getting it, then maybe you do need to think about getting vaccinated for measles or any other illness that you could be at risk for. But it's tricky though, right? Because the live vaccines piece, if someone's on, I don't know, a B cell depleter, and we have to be very thoughtful of live vaccines, and maybe behavioral interventions is really the most important beyond vaccination, especially if your vaccine response is going to be attenuated. So it might not even work,
Yeah.
in that context. So behavioral interventions, I think we underestimate how well that can work.
Well, I think we're probably coming to around the end of our time, and I want to thank Dr. Scott Newsome so much for being here. I would say that we've learned a lot. I learned a lot about the Treat MS study, and the wealth of information we expect to get from patients who may have been in the study as long as 8 years by the time it ends. My fingers are crossed for you and your colleagues to get additional funding to keep following these 900 patients around the United States. This is going to add a lot to our understanding of the disease, I believe. And we've also discussed shared decision making and vaccinations for people with MS. I want to thank all of our audience for listening in. Thank you again, Dr. Newsome. And this is Dr. Ann Cross signing off for In Discussion.
Thanks for listening to Medscape's In Discussion Multiple Sclerosis podcast series with our host, Dr. Ann Cross. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on multiple sclerosis.